not just one of our routine rheumatologic diseases, but of great interest. And we're very pleased to get back Dr. Glenn Haugeberg, who's going to talk to us about registries. I think registries are something we're seeing more and more of, and it's a question: how do we take the data from registries? What are the considerations that go into a registry that really speak to how we can use the data? And Glenn is a fantastic person to do this because he has very personal experience developing registries, and also ask him to talk about some of the other registries where there are quite a number of them in Europe, and say what information we can get from those. Welcome back, Glenn.
Thank you. Yes, my interest in registries, I became interested because when I was starting my training as a rheumatologist, I experienced that I could not, if someone asked me, how are you treating your patients, I could just give my opinion about it, but I couldn't give the figures. I couldn't tell the mean hack of my patient, I couldn't tell the DAS, I couldn't tell more or less anything. So I got interested. It was a kind of a mess in it. So this is the topic of my talk. Registries in rheumatology, a European perspective. My disclosure, I've been involved in developing a computer system, which will be mentioned during my talk. Here is the outline. I want to make some reflections on evidence medicine, RCT, registries, strengths and limitations, and types of registries and why registries in rheumatology became important. Results achieved from registries in Europe and what have we learned from the registries. And of course, it is a huge topic, so I will only scratch a little bit on some of that, give some teasers. And the last question I want to address is there still room for register improvement? I want to start with this wonderful painting from Caravaggio. What we as doctors, we want to have evidence. We want to know when the methods we are using that they really say the right thing. We want to know that the drugs works and so on. So we are skeptical. Well, the beauty about the science goes really far back to the ancient Greeks. And here to quote Aristotle, science refers to the body of reliable knowledge, and that's what it is about. But Plato, I like this allegory of the cave from Plato, because he in some way realized that it's not always that easy it may be that what you see, you're sitting here, and what you see may be misinterpreted. It may be something else which is behind. So we are talking then, of course, about bias, systematic errors. And studies we know can be biased because of, in different ways, the way in which the subject have been selected, the way the study variables are measured, or some confounding fact that is not completely controlled for. So, but we are using different methods, study methods to get this knowledge, and we see that the randomized controlled trials, they are on the top of the pyramid when we're talking about causality. So there is no better methods. But as doctors, we also know it's not only about evidence. Evidence is one part of what goes into making clinical decision. It's also about patients' concern. It's about our clinical experience. It has to be taken into consideration. And you have all the legal issues which we have to deal with in our clinical practice. And I heard a lot of these concerns you are dealing with the reimbursement issues too. Well, this very simple slide demonstrates some of the problems we are causing with if you are only relying on randomized controlled trials. When we have all the patients, there is a heterogeneous group, even in one diagnosis. Then we are selecting patients for studies, for RCTs, and then we take all the information we have from our RCTs and we apply it on the whole population again. And of course, the limitations of RCTs are then obvious. Subjects are highly selected, and the question is, do the responses in RCTs reflect those seen in clinical practice? Important questions. How do adverse event profile compare between RCTs and clinical practice, and how can RCT estimate risk of rare but important outcomes? And that's some of the difficulties with the RCTs, and also the limitations of the RCTs. So the registries are in some way cohort studies. So we are sacrificing a little bit on causality, but we get, there are advantages using registries which are obvious. And we need these registries because some questions may not be adequately answered by the RCTs, like long-term safety, long-term efficacy, and treatment. You can also do treatment comparisons in the absence of head-to-head trials. Of course, the quality of that kind of studies is lower than doing a RCT. But anyway, you can at least get some kind of information out of it. And information from different national registries, they can provide real-life, long-term data in patients with comorbidities. A lot of these patients with comorbidities, they're not into their RCTs. And the registries provide feedback on the management of rheumatic condition in real life. They can inform the clinical decision making, so we get additional information in together with RCTs. The data sources for real life is you can use healthcare databases, claims data, or registry data, which I will talk about. And of course, we could imagine we could have this ideal situation where we are monitoring all our patients. Then you have the true population-based registries. I will come back to that at the end of my talk. So there are always pros and cons with everything. So the disadvantages also for registries are also obvious, as listed here. Non-randomized, as you know, confounding by indication, missing data, potential for confounding factors, channeling bias, and choice of reference group, and so on and so on. So, of course, there are limitations. But the thing is that the RCTs often gives the proof of the concept. Does a drug work or does it not work? However, the question will be then, if you apply it on all the patients you have, in the heterogeneous group, is the proof in practice we are talking about. Does it also work when in my clinical setting? I like to quote Curtis, the evidence, implementation, and implementation size. And to quote him, the dissemination and uptake of best practices into clinical care is sometimes a neglected component of research that is essential to improve the population's health. Well, when the biologics came on the market, it was clear that there was a concern about the long-term safety of the biologics, infections, cancer, and so on. So there was a group who wrote this paper in Annals of Rheumatic Diseases in 2000, where they come up with a proposal to establish a register for the long-term surveillance of adverse events in patient rheumatic diseases exposed to biologic agents. Well, it turned out not only to be one register which came out of that is the heterogeneity of Europe, a lot of countries, and everybody wanted to make their own registry. And here you can see that we have a lot of them. You have, I've only show you the artist register from Sweden here, but they have many more. The Norwegian NODIMAT register, you have the British BSR-BR register, you have the French registries, you have the Spanish BIOBADASER, you have the Dutch DREAM register, you have the Italian Laurent Gisea registry, and you have the German Rabbit registry and the famous Danbio registry in Denmark. So here you see there's a lot of interest into this topic. And here you see when they started here you can see that most of the registries which have been developed as biologic registries. There are some registries, however, who also including patients who are starting on DMARDs, and I want to highlight the NODIMAT registry in Norway, where both synthetic and biologic DMARDs are included, and then also the Danbio registry in Denmark, which started in 2000, including biologic drugs only, but after 2005, they also included synthetic DMARDs. Well, as you can see here, all these registries more or less popped up in the beginning of the 2001, that was not a good example, but 2000, 2002, 2003, and so on. And you can see there is a large number of patients included in these registers here, about more than 90,000 individuals. So registries. Well, registries you can use to explore what's happening in the real world. We can say something about the patient population exposed to the drugs here, and you can say something about drug efficacy. And here now I want to show you some example. Here are the examples for an publication from BSRBR register, where they wanted to look on the changes in disease characteristics and responses in patients who were received with who received biologics in the period from 2001 to 2008, and they concluded it's to be expected that patients with rheumatoid are receiving TNF therapies early in the disease as we have got more experience with it. Many patients still receive their first anti-TNF drug after the first 5 years of disease. That's the situation in UK, because they have to have a high disease activity to get a biologic drug in UK. They have more problems to get it. Then response scores and remission rates have improved significantly since the earliest use of anti-TNF. That was a conclusion from this study, reassuring that we are on the right path. Well, here again, for some data from the ARTIST study in Sweden, it's pretty reassuring that when you're looking at rheumatoid, you're looking at spondyloarthropathies and PSA, you can see either you started in 2000 with the drug, 2000 in the drug, 2003, or 2006, you have the same survival rates. You can see here also that during this follow-up period, the patients who started in the early period with biologics, to be expected, they were more diseased. Here are some data, efficacy data from the DREAM registry from the Netherlands. You can see that it looks as if, of course, with all the limitations we have to take into consideration about registries data, but it looks as if the etanercept and adalimumab is performing better than infliximab in this register. And we know that the combination here, data from the Lauren register, the Italian one, they're looking also at the efficacy of anti-TNFs in rheumatoid. They nicely demonstrated what we knew from the confirming what we knew from the randomized controlled trial, that combining a DMARD with TNF is better than only giving anti-TNF in monotherapy. Well, that is not very new information, but it's confirming what we know from that we should combine these drugs in clinic. Here, drug survival of the TNF inhibitors from the ARTIST studies, that you can see, there seems to be a difference between the drugs. Here, after 5 years, you can see that at the end of the 5-year follow-up, 38% of the infliximab, 50% of the adalimumab, and 50% of the etanercept initiators remained on the first drug. So you can see that it seems that infliximab seems to do a little bit worse than the two other TNF inhibitors. Here's some data from the BioBadazar register with the rate of looking at the rate of discontinuation among anti-TNF, and it looks as if the reason to discontinuate due to inefficacy, it looks as that it may be a little bit higher for infliximab, but if you look at adverse events, it looks as if etanercept is doing a little bit better. What about, the huge advantage of the TNF biologic drugs was related to the radiographic progression, and that was a huge step forward in this. And this has been explored also in the DAN-BIO register. Here you can see patients who were in the DMARD period, they had an increase in SHARP score. When they came over the TNF inhibitor period, you can see that these patients did not hardly had any further progression in radiographic joint damage. So what about safety issues? Here is a list: mortality, infection, cancer, heart disease, all these kind of issues has been tried to be addressed in the registries, these concerns. It's also about money, these huge expensive drugs. So what about cost effectiveness and sick leave disability pension? If you could say one not going into a disability pension, it may be worth from the society perspective that patient should have these drugs, expensive drugs, because at the end of the day you may save money. Mortality, This is data from the SSATG Malmö cohort register. And as you can see here nicely from this study, they find that patients with a high HAQ score who are not on TNF inhibitor had a higher mortality rate than compared with patients who had high HAQ and were on TNF inhibitors. For me as a clinician, it's pretty reassuring. It looks as if we are not killing our patients, we are doing something good for them. So this question about mortality also been looked into the BioBudSR register, and they also concluding here that mortality are not higher than expected in patients with rheumatoid treated with TNF antagonists. Again, reassuring. It looks to be safe also from the perspective of mortality. What about infections? Well, we know that these drugs increase the risk of infection. It's been explored in the BSRBR British registry, concluding here, of course, as we know, serious skin and soft infections, they were increased in this cohort. Here also, this has been looked into the Italian GISEA study, looking into long-term anti-TNF therapy and risk of serious infection. Interestingly is that you can see we are focusing on the TNF inhibitors as the bad guy, but look at use of steroids. Half of my patients are on steroids. It's a risk predictor of infection, concomitant DMARD treatment, advanced age as a start of anti-TNF treatment. You have the use of infliximab here, seems to be give a higher risk of infection compared with etanercept. The same for adalimumab. That adalimumab also seems to give a higher risk of infection compared to etanercept. So from the authors of this study, they conclude that anti-TNF therapy is associated with a small but significant risk of serious infection, and serious infection is associated with the concomitant use of steroids and advanced age at the start of anti-TNF treatment, and the type of anti-TNF treatment seems also to be an issue. Well, what about infections over time? When are the patient at the highest risk for soft tissue infections? This question was addressed using again the British BSRBR register, and it seems that it is more of higher risk in the beginning than later during follow-up. That both for shingles and for serious skin and soft tissue infections. It has been in the beginning of this meeting. It has also been mentioned this rabbit risk score for serious infection, and it's nicely to see that from the rabbit register they have identified these risks for having an infection, and they have explored to see using the register data and the risk factors to see if there is that you get the same figures when you're looking on expected and observed data. So when you have this situation of you can make the risk factors, you can also develop a algorithm which is useful, I think, for clinical use. That is, of course, if you look here with the glucocorticoids, the more glucocorticosteroids you use, the higher the risk is you have for having an infection. But if you take all the additional risk factors into account, like age you see that they are dramatically increasing. So that's a nice thing. That's an interesting way where we have got a little tool for clinical use, where we can in some way put patients in groups to see if they are at low risk, at moderate risk, or at high risk of infections. So what about cancer? Well, that was a huge concern when the biologics came on the market, and this has been addressed in the Swedish register. In Sweden, they have the opportunity to connect different registers and population registers, cancer registers, with these biologic register. And their conclusion they concluded after having looking into this that overall patients with rheumatoid are at equally increased risk for lymphomas and leukemias. And patients with rheumatoid treated with TNF antagonists did not have higher lymphoma risk than other patients with rheumatoid arthritis. And they're concluding also a prolonged observation is needed to determine the long-term effect of TNF antagonists on lymphoma risk. Well, for me as a clinician, is always this concern when the patients are coming in and asking, what about the infection risk? What about the cancer risk? And for me, it's reassuring when you can show that kind of data. Here again from the Swedish register, that patients exposed to biologics and compared with those not exposed to biologics, you can see that the curves are much the same, overlapping when you're looking into all cancer, you're looking into lung cancer, colorectal, hematologic cancer. Well, what about cancer risk over time? Because cancer, that's not like infection, it goes pretty quick. But what about cancer over time when you are using biologics? And I think these data, again, also are pretty reassuring, that demonstrating that if you have been using the biologics or the TNF inhibitors for more than 6 years, it does not seem to increase the risk of having cancer, which again is pretty reassuring. Risk of solid cancer, patient with rheumatoid arthritis and after treatment tumor necrosis factor antagonist. Here again from Askling's group in Karolinska, concluding that the cancer patient in patient treated with TNF antagonists mirrors those of other contemporary as well as historic rheumatoid cohorts. Well, I want to show you these slides to you, because of course you have the opportunity to collaborate with and combine data from registries. And here they have been combining data from the rabbit registry. You have the BSRBR UK registry, the ARTIS registry. And here the question they want to address was if leflunomide was associated with an increased risk of pancreatic cancer. And their conclusion was that the hypothesis of this was that it does not seem to increase this risk. And there you see the beauty about registries. You know, if you have a lot of data, you can go back, and you can, if there is some concern coming up, you may have the opportunity to go back and to test if it's really the case. Heart diseases. Here, data from the Danish National Patient Registry. Well, I think there is some message we as rheumatologists has to give to the GPs. Well, if you ask a GP if a patient with diabetes is at increased risk for cardiovascular disease, he will say, oh, definitely yes. If you ask him the same question about rheumatoid, he would say, who would not associate a rheumatoid with having an increased risk of cardiovascular disease. So what they demonstrated in this registry, as we know, after full adjustment, rheumatoid was associated with the same risk of myocardial infarction as diabetes, and that is a message I think we have to bring more clearly forward to the GPs, at least in Norway. Here another study, some results from the ARTIS study, looking into treatment with tumor necrosis factors, factor blockers. They found that it was associated with a lower incidence of first cardiovascular events in patients with rheumatoid arthritis. So it didn't seem to be harmful from that perspective, rather beneficial. Well, they also tried to address the question about acute coronary syndrome in early rheumatoid arthritis. They concluded from this study that in patients treated with anti-TNF within the first years of rheumatoid, neither treatment with nor response to anti-TNF could be linked to any statistically significant decrease in the risk of acute coronary syndrome. But at least we didn't increase it. And what about heart failure in patients with rheumatoid arthritis treated with tumor necrosis factor inhibitor? Here, results from was looked into using the rabbit registry, concluding that the findings of this study indicate that TNF alpha inhibitor treatment that effectively reduced inflammatory activity in rheumatoid is more likely to be beneficial than harmful with regard to risk of heart failure. While others, as I mentioned, the beauty about registry is that you can go back and test hypotheses. And I don't know why this hypothesis came up of gastrointestinal perforation, but at least they looked into using the BSR-BR register and concluded that we have not found a statistically significant association between anti-TNF treatment and the risk of GIP. And so you can using it as an example. The same thing with risk of venous thrombotic events in rheumatoid arthritis patients. Well, when looking into the BSR-BR register, they found that overall there is no difference in rate of venous thrombotic events between TNF inhibitor and DMR-treated patients. And the risk is similar across all TNF inhibitors. Well, seldom diseases like progressive multifocal leukoencephalopathy. Again, you need large numbers to say about something about rare conditions or side adverse events. And here illustrated that with the progressive multifocal leukoencephalopathy, where they conclude that there may be an increased risk of this condition in patients with rheumatoid arthritis. It's not big, but it's maybe there. Pregnancy, just a brief little word comment to that too. Anti-TNF therapies and pregnancy. It has been looked into this also, and it's pretty reassuring again that it looks at it. It does not have. There is only a few reports of congenital malformation in it. Of course, we do not like to use drugs anyway when women are pregnant, but it's again reassuring. Cost effectiveness, there's a huge topic. I won't go into that because that's really big. But of course, that's a big issue for the payers, that they want to see that is actually of great importance when we're putting that much effort and money into it. We want to see the benefit. That's there we also have nice data from the artist registry. The Swedes are very good at that at the Karolinska Institute. Sick leave, disability pension, again a huge topic. I mean, if you can avoid that a patient is going on sick leave or have to get disability pension, that's a huge issue for the society, and also for the individual, of course, that his income is going down. And here again, the workability in rheumatoid nicely demonstrated in the artist register, where they conclude that biologic therapy was associated with increases in workforce participation in a group typically expect to experience progressively deteriorating ability to work. And here again, again from this artist study demonstrating here nicely, here is the general population regarding days of sick leave, and here you can see with a patient who become diagnosed with rheumatoid arthritis and getting on treatment, they're dropping down. That is the mean of days of sick leave. But when you look at the median, it's very impressive. Okay, half of the population it goes up, but a lot of our patient returns back to work. And that is of great importance for the society and for the patient themselves, of course. Here another slide just demonstrating the same thing, that of course it increases and then it is reduced compared with the, and here you can see the curve of the general population and how it occurs for the rheumatoids. Well, a few words to the future and modern registries. Where do we go with the registries? Well, because as I have emphasize, well, the limitation and the strengths of RCTs are obvious. There are limitations, as I see it, also from registries. They are also selecting the patients, and as I said in the beginning of my talk, that it would be better to monitor all our patients. That would in some way be, from my point of view, the ideal situation. So, and the Dan-Bio actually has followed this principle, because when they started with the register in 2000, they were only focusing on biologic drugs. But in 2005, they introduced what they call the Dan-Bio Online. And what is that? Well, that is actually some kind of electronic patient record system for the doctor to be used in clinical care. So he gets immediately feedback from the system. It's a monitoring system. You have the patient, you're putting the data in, and you get it displayed on the graph, how well the patient is performing. And as you can see here, the result of that, here you can see for the biologic agents, you can see how many patients has been included for PSA, AS, rheumatoid, and then you see here for the DMARDs, they started in 2000, hardly any patient with DMARDs were included, but then you come to 2005, introducing Dan-Bio Online, where we give the clinician a tool which he benefit from using. Then they also managed to include a lot of DMARD, a lot of patients using DMARDs. This is some work we have been producing. That was presented at the EULAR meeting, and it is a Norwegian initiative we call the Bioroma. And the thing, the idea behind this is that we want to monitor our patients. It's a kind of benchmarking, but we also want to have the benefit of it, that we can make a register out of it. The red dots are the participating centers in Norway. And we have been collaborating, Tuulikki Saka from Jyväskylä in Finland. She is, in her hospital, they are covering this area in Finland. In my hospital in southern part of Norway, we are covering this area. And as you can see, the population of these two areas is pretty much the same. Our attempt is to monitor all our patients. So here, of course, it's a huge limitation with comparing like this, but it's just, at some stage you get some feeling of what kind of data you have and how well are your patient performing. So you should not overinterpret these, of course. But it's interesting to see that the Finns seems to perform better. Either they are not that good to count the joints. That may be one possibility. Of course, they are Finns. They there are not that many tended joint counts, because if comparing a Norwegian with a Finn, the Finns they can take more pain, we believe. Who knows? But when you come to the ESR, at least you can't argue against ESR, and you can't argue against CRP. Okay, you could due to the different laboratories, but if you take that, you can see still difference between the two hospitals in the two countries, and so you can go down the medical MD Global, the Doctors Global is equal. So there's no significance. So it seems that the Finns patients are performing better than our patients, if we will interpret it that way. Well, if you look into how we are treating our patients, the huge differences come. There we are using 33% of our patients are, 33% of our patients are on biologics, 17% in Jyväskylä. But they managed to put patients in combination. That's probably due to their history behind this use of it. When it comes to paying of this, then you see that it is more expensive. At least we are putting more money into this than they are doing. But of course, you're cautious with making interpretation. But at least that's how it looks. So in summary, just a short summary, registries, I think, is a really important source for knowledge. And I think it's especially important for us who are in clinical care. And I think for the future, I believe that centers will have their own registry where they can give the data and tell how are we performing, how are we treating our patient, and giving answers to these very, unsexy questions from the research point of view, but may be very useful. Thank you.
Thank you very much, Glenn. That was a tour de force of a ton of data. Any questions and discussion? As people are thinking, coming up to the microphone, one of the issues we have in the U.S., I think, when we think about the registries, is that patients have to really voluntarily participate and consent to be in the registry. Among the different European registries, I know in some they consent. In some, it's almost you can consent, but if you don't consent, you may run a chance of not getting the biologic, like in the UK. What about the other European registries? Is consenting considered a part of it, or is it just considered more that it's so useful information that we need to have this information from you?
Yeah, I think that the most of the registries, I haven't the details about it in all, but most of them are based on consent. You have to do that. But the thing is, like what the data I showed you from Norway and Finland, well, there is a discrepancy because due to the regulations, if you're only collecting data which you're doing for clinical purpose, to monitor the patient, then it's like a CRP or ESR. Then you are allowed to use that data because it's not considered to be research. It is quality. Yeah, so that's the balance. But if you are introducing something new, I want to explore this or that, a test or whatever, then you are, that's research. So that's how it's defined, at least in Norway. So whatever you can retrospectively then go back to your clinical data, which was you collected due to clinical work, then you can use it. You have to apply, but you get a letter back. This is no research. This is quality data.
Front right.
So, Glenn, very interesting talk, and I think very important talk. I'm always troubled by registries because I don't know what makes up the registry. I don't know what's the strength of a particular registry or the weakness of a particular registry. Is there any way to get that type of data? So what I'm talking about is, as already said, if a patient signs up, has to sign up, and all you get are patients who are really doing really well, versus real life where they're really not doing well, the data from that registry is not going to be real life. Is there any way to really know the differences?
Well, as you see, that there are obvious limitations of the registries and their confoundings and all that. It's a huge, but it tells you at least one thing. It tells at least one thing. How you are treating patients, what are you actually doing with the patient. Number two, you get some information of what kind of level you have put these patients as a group. And the other thing by having registers is also that you can see which patients are still not in the group you want to have them, like remission or low disease activity, moving toward the EULAR recommendation, of putting patient into remission or low disease activity. So in some way you can use these data also as a strategy tool to see which patients should we put more effort into, and which patient do we not need to have that much concern. Like putting up, some patient you may be followed by a nurse. If you are in remission, you will be in remission, so you may be fine, and you don't need to see the doctor. The doctor perhaps only, so it's more, I see more useful from that point of view, of course, to just see how are we performing, where can we do better, and so on.
That was really nice talk, and I guess maybe a corollary to what Dr. Fleischman just asked. I mean, any registry is only as good as the information going in there, and so the question then is, how do you incentivize or make sure that the participant physicians are actually really keeping up with it and entering the data that you want. I mean, it takes extra time. And having participated in some of these and a participant in the Corona Registry, you know, if you're a half hour behind in clinic one day and you've got a new patient who you want to put in the registry and you know that's going to take you 20 minutes that you just don't have, you go, I don't think
I agree.
so. So how do you address that to make sure you get the data you want?
That's the reason why I'm not participating in an ODMA registry in Norway. Because it takes me too much time often. And you need, and this has been put up as a study. Well, I'm more in favor of the philosophy of giving, that, to be honest with you, that was the reason why I developed this too, because when I started rheumatology, it was a mess. Medical record system was crap. So I got confused. So I'm a simple guy. I need to have some illuminate these things. So I think that where we need to move on is that we need to give to have the doctors to have an instrument, a tool, a computer tool, or whatever what it is. And I think that's what the Done Bio has done. You know, they have been moved on to this benchmarking thinking. Right. So that is because the doctors, when you develop that kind of tool, it should be of the benefit for the doctor, not for Professor Haugeberg, who wants to make a paper. Right. And that's the difference.
All right. Thank you very much, Glenn. That was a great.